Can you all see my screen?
You are now unmuted.
Yes, madam.
Yes, we can see that.
Okay. An approach to a patient with antimicrobial allergy. So that's the topic. So the outline of my presentation would be briefly introduce to some of the types of antibiotic hypersensitivity reactions and their presentations. Very briefly as an introduction to my presentation, because they were already dealt with by Danushka. And then I'll be discussing some common antimicrobials to cause hypersensitivity or allergic reactions. And the main topic would be to how to approach a patient with a history of allergy to antimicrobials. So these are the topics of my presentation. And I'll be presenting two cases. And this patient whom I saw beginning of this year, about 4 months ago, a middle-aged woman, she was referred for a skin prick test for allergy evaluation, as she was reported to be allergic to several antibiotics. And she was awaiting a surgery under GA, a gynecological surgery. So the surgeon was very worried to give anesthesia and also to give any antibiotic. So she was reported to be allergic to amoxicillin, cloxacillin, cefuroxime, and clarithromycin. So the next case is a very young mother who had developed anaphylaxis during general anesthesia for LSCS, and she was managed in the ICU for more than a week, and she was referred for a skin prick test after 2 months of the reaction, and she was given an array of general anesthetic drugs and also given ceftriaxone at induction. So I'll be discussing these two cases. And just about antibiotic allergy, and unlike other medical conditions, they are commonly overreported, and most of these reports are found to be a mislabel when they are appropriately evaluated, tested, and rechallenged. And the diagnosis of these antibiotic allergies is very difficult because the tests are not readily available, and some tests have low sensitivity and specificity. And the treatment is going to be sometimes a nightmare when, sometimes when patients come and say they're allergic to so many antibiotics, to choose an antibiotic, it's sometimes very difficult. And these patients who had a reaction to a drug they're often anxious about taking drugs. And also the treating physicians are also worried to give drugs. So it's a common problem that we encounter. And this result in commencement of an alternative, sometimes an inferior second-line antibiotic over the first choice for treatment of infections and sometimes prophylaxis. And this can affect the patient management, morbidity, and mortality of patients because you are not treating with the best option. As Danushka also mentioned, allergies can be immune-mediated, and some of them are non-immune mediated, and they are also known as pseudoallergies, or now they were referred to as anaphylactoid reactions, but now we are using the term non-immunologic anaphylaxis. So they are non-immune mediated, meaning that they are not mediated by antibodies or T cells, so they don't have memory. But immune-mediated reactions are mediated by antibodies or T cells, so they have memory. Right, so these non-immune-mediated reactions are mainly due to direct mast cell activation or basophil activation or sometimes complement activation by the drug. So they don't involve any immune cells like the B cells or the T cells, but they directly activate the mast cells and basophils. Right, so when a patient comes with symptoms of an allergy, so not all symptoms can be attributed to like a drug hypersensitivity reaction. So many things can happen when you start a drug. So these symptoms can be due to side effects, known side effects of the drug. So there are various adverse reactions, as Danushka mentioned, right? So you have to think of all the things, possible things, right? So sometimes when patients, so especially patients, they think when they have some symptoms following a drug, it's due to an allergy or intolerance. So that they think that they are allergic to that particular drug. So, but in your clinical evaluation, you have to go into the details of the history and see whether there are just side effects of the drug or there are interactions, drug-to-drug interaction. They could be just intolerance. So you have to think of all the possibilities without just taking all symptoms and think that it's just a drug hypersensitivity reaction. Now, just to show you the record which the first patient came with. So she was reported to be allergic to Piriton and the antibiotics that I mentioned earlier, amoxicillin, cefuroxime, clarithromycin, cloxacillin, and some herbal medicines, and queriketotifen, fexofenadine, food allergy plus, I think it's hair dye, and on the side it says systemic involvement plus. So when you have a record like this, when you see a record like this, so you're so worried to start an antibiotic, especially when this patient is awaiting a surgery under GA. So no wonder why the gynecologist was so worried, the anesthetist was so worried to give even general anesthesia to this patient. So they wanted me to test for general anesthetic also, but I convinced them. So when I asked the patient what happens with Piriton, she says that she feels excessively sleepy with Piriton. Like she can't wake up from the bed. So that's a known side effect of Piriton. And, with ketotifen, fexofenadine, she said she feels drowsy, some muscle aches and muscle twitching. Those are the symptoms that she, came up with. So you have to, when you evaluate the clinical history, you have to, before recording it, you have to, thoroughly go into the history and see whether it's really an allergic reaction. Now, these, as Danushka mentioned, these allergy labels are very common, and most of them are self-reported. Patients themselves come and say that they are allergic to an antibiotics, and sometimes these symptoms are very ambiguous, very subjective, and sometimes these events have been, have occurred so many years ago. Those historical childhood events, even they can't remember. Maybe their parents have told them, or just a family history, or they might misinterpret a non-allergic adverse effect, like intolerance, or sometimes just with infections, like viral infections, they can get skin rashes. So sometimes they can misinterpret those skin rashes with a allergy. And these allergy labels can also be created by medical people, by inadequate documents or inappropriate documents or records, right? So when you take the history, you ask for history of drug allergy, and when they say yes, you ask which drug, and sometimes the patients don't know the name of the drug and they just describe, saying that the drug was prescribed for an infection and it was like this color, blue and white, and then you assume that it's amoxicillin and you record as amoxicillin allergy, and you don't go into details of the reaction, and sometimes you just record it as a amoxicillin allergy, and these records will go on and they get stuck at some point, and they are fixed to sometimes to a diagnosis card. And sometimes we act upon these mislabels without any clarification. And sometimes we can overestimate the cross-reactivity, especially with the beta-lactams. Sometimes if the patient comes and say they're allergic to penicillin, you don't want to start any beta-lactam. So you might overestimate the cross-reactivity between the beta-lactams. So even if the patient had a true IgE-mediated reaction, these allergies wane over time. They grow out of it. About 80% of patients become tolerant to that culprit antibiotic after a decade. So it's a significant proportion. Significant proportion of patients lose their allergy with time. So even if they had a true allergy, they might not have the allergy now. So these labels, mislabels, can create a big problem. They have a very bad impact on patient outcome. And they can have a negative impact on antibiotic utilization and also a negative impact on the development of resistance organisms. Are my slides moving? I hope my slides are moving, right?
Yes. Yes. Thanks.
Okay. Thank you. Right, so this table shows all the types of reactions that could happen with an antibiotic. I think that Danushka has already mentioned all these types of reactions. So you can classify the reactions into two groups. Immediate reactions, those occur within 1 hour of starting a drug, or non-immediate reaction after so many hours, days or weeks. So we are mostly concerned of this type 1 or immediate type hypersensitivity reactions, which usually occur within minutes of starting the culprit drug. And the non-immediate reactions could be various types with various presentations, and sometimes they can also present as a severe reaction, severe cutaneous adverse reaction, such as BRESS, SJS, and toxic epidermal necrolysis. So they can also have severe reactions. So I'm not going to details of the different types of hypersensitivity reaction. Right, so we will discuss what are the common antibiotics to cause, antimicrobials to cause reactions. So mostly the beta-lactams, because they are the most commonly used antibiotics, class of antibiotics, the penicillins and the cephalosporins. So they are the most commonly, they most commonly cause hypersensitivity reactions. And then the fluoroquinolones, a very trendy class of drug nowadays, because you use fluoroquinolones a lot. So the incidence of reactions to fluoroquinolones has also increased now. Vancomycin can also cause reactions, and also Amphotericin B and antifungal is also, is commonly cause reactions in some patients. Right, so penicillins, when you talk of penicillins, they can be oral penicillin, IV benzathine, or aminopenicillin such as amoxicillin, ampicillin, and then anti-staph like cloxacillin, then antistudio like ticagrelin, and all those come under penicillins. And so the most common culprit for hypersensitivity reactions historically is the penicillin group. So the reported rate for penicillin hypersensitivity reaction is about 5 to 15% in literature, but when they are tested and challenged, more than 95% of these patients could tolerate the culprit drug. And children might have a even lower incidence of true penicillin allergy than reported, because most of the skin reactions that they thought that it's due to hypersensitivity could be due to viral exanthems, viral infections that these, the children might commonly encounter. So these symptoms, skin presentations can be confused with a hypersensitivity reaction to penicillins. So even the the patients who had a true allergic reaction to penicillin, approximately about 8 to 10% of these patients grow out of their allergies each year. So it's a significant proportion. So each year, 10% of patients lose their skin reactivity. So they will be able to tolerate the culprit penicillin. And some patients have a selective IgE-mediated reactions to aminopenicillin. So they are only allergic to aminopenicillin group without being allergic to other penicillins in the main group. And sometimes they are allergic only to clavulanic acid. And what about the cross-reactivity of penicillins? Now, among the different types of penicillins in the same group of penicillins, they can cross-react. But cross-reactivity with other beta-lactams has been overestimated in the past, right? So earlier, the cross-reactivity with cephalosporin was reported to be very high, about 5 to 10%. But now they estimate that it's less than 2%, which cross-react with cephalosporin. So penicillin and cephalosporin cross-reactivity is now thought to be less than 2%. And this is mainly for the first generation cephalosporins and some early second generation cephalosporins. So if you have a patient with like penicillin allergy, so you have to avoid first generation and second generation cephalosporins. And this is so common with patients who have selective aminopenicillin allergy. Like if they're especially allergic to aminopenicillins like amoxicillin, you have to avoid first generation and second generation cephalosporins. And the cross-reactivity with carbapenems is negligible. It's less than 1%, and there is no cross-reactivity with monobactams. So a study done with over 200 patients confirmed patients with penicillin allergy with positive skin prick test. So they're confirmed to have penicillin allergy. And these patients had negative skin test results with carbapenems and monobactams, and they could tolerate carbapenems and monobactams without a problem. So in other words, you may be able to start monobactam or carbapenems in a patient who had a reaction to penicillin. Now, this was shown earlier also by Danushka. So this shows the structure of beta-lactam. So they share the beta-lactam ring, but the side chains are different. So the cross-reactivity is mainly for the side chains. So they are mainly directed to the structurally similar identical side chains. So you have to avoid beta-lactams with structurally similar R1 side chain. Now, cephalosporin allergy is reported to be about 1 to 2%, and again the cross-reactivity among cephalosporin is also rare because of the heterogeneity of the R1 side chains. So different cephalosporins have different R1 side chains. So you have to avoid re-exposure to a cephalosporin and other beta-lactams that share the same R1 side chain. So in other words, it's safer to administer a cephalosporin with a dissimilar side chain. And similar to penicillin allergy, cephalosporins also lose their skin reactivity over time. So these patients can also tolerate cephalosporin after some time. And ceftazidime especially cross-react with aztreonam. Aztreonam is the least cross-reactive beta-lactam because it has a different structure, completely different structure to other beta-lactams, but it can cross-react with ceftazidime. And the cross-reactivity of cephalosporins with carbapenems is again very low. And this table shows the cross-reactive beta-lactams. So you can see the so the penicillins and first and second generation cephalosporins can cross-react with each other. So within the penicillin group, they can cross-react, and penicillins can cross-react with first and second generation cephalosporins. So you have to avoid first and second generation cephalosporins. And third and fourth generation cephalosporins, they cross-react with each other in the same group and within the second and third and fourth generation cephalosporins. And the carbapenems, they cross-react with each other in the same group, And the monobactams are the least reactive, and they only cross-react with ceftazidime. Now, fluoroquinolones, the incidence has increased because of the increased use of fluoroquinolones, but the true IgE-mediated anaphylactic reactions were very rare. Now, we had several anaphylaxis cases with fluoroquinolones, but the true IgE-mediated cases reactions are rare. Moxifloxacin can cause more reactions than Cipro and Levo, and the main reaction is due to non-immunological phenomena. Like, they can these fluoroquinolones can directly activate the mast cells and basophils, causing the degranulation of mast cells, and the symptoms may be similar to anaphylaxis. So, as Danishka mentioned, they can have more skin symptoms, but, sometimes clinically you can't distinguish between anaphylaxis and this true anaphylaxis, IgE-mediated anaphylaxis and non-immunological mediated anaphylaxis. So they have same symptoms, but they don't have memory. So you may be able to give fluoroquinolones without a problem later on. And cross-reactivity between fluoroquinolones in the same group of fluoroquinolones can be there with the true IgE-mediated reactions. So you have to avoid other fluoroquinolones if they had a reaction to one fluoroquinolone. Vancomycin, again, true IgE reactions are rare. Again, the reactions are mainly due to direct histamine release by mast cells, which gives rise to this red man syndrome. This is associated with rapid infusion of the first dose of vancomycin. So, 1/3 of patients will develop red man syndrome if they are given vancomycin very fast infusions. So, the recurrence is low provided that the drug is infused more slowly. So, you can restart vancomycin slowly. And there are some conditions which can increase this, mast cell degranulation, increase the risk of mast cell degranulation. So you have to avoid some other drugs like muscle relaxants, opioids, and some conditions can increase the risk. And vancomycin not only cause red man syndrome, but they are also responsible for 40% of DRESS and fixed drug eruptions. So they can commonly cause other severe cutaneous adverse reactions as well, which are T-cell mediated. Now, Amphotericin, again, the true IgE-mediated reactions are rare. Again, there are infusion-related reactions, and commonly these patients develop the reaction with the first few doses, most commonly with the first dose, shortly after the first dose, but the reactions tend to level off after repeated administration, and the reactions are less with liposomal preparations. So you have to slow down the infusion rate, and again the reactions, as I said before, are due to drugs being able to directly activate the mast cells and directly activate the complement system. So you have to slow down the infusion, and sometimes you can do pre-medication as well. Now, the main question, how to approach a patient with antibiotic allergy. So the clinical evaluation is very, very important. History is the most important first step. So in the history, you have to make sure that it is an allergic reaction, and the allergic reaction is due to this particular, the culprit drug, right? So, sometimes some patients have a condition known as chronic urticaria, chronic idiopathic urticaria, and time to time they develop this urticaria, right? And sometimes they think that this urticaria, when they are on antibiotics, they think that this urticaria is due to the antibiotic which they were given, but it's not so, because they, even without the antibiotic, they get urticaria time to time. So in the history, it's important that you exclude that chronic idiopathic urticaria, because it is a very common condition nowadays. So history is very important. So to make sure that it's a drug allergy, right? Not any other adverse reaction to the drug. And the investigations, as Danishka mentioned, the skin prick test is the first line test to identify the allergen, right? So it's the first line in adults, and it can be done for children with a history of anaphylaxis to a drug. And if the skin prick test is negative, you can proceed with the intradermal test. And if the intradermal test is also negative, you can proceed with the challenge. So you can do a direct challenge, or, provocation by giving the whole dose, or you can do a graded challenge by dividing into multiple doses. And there are other tests like basophil activation test, which is a very sensitive and a specific test to identify IgE-mediated reactions, but it's not available. And then specific IgE, again, not a very good test, very low sensitivity and specificity. And serum tryptase test can be done in if the patient had an anaphylaxis. Now, history, what are the important points that you have to ask in the history, right? The symptoms, right? What are the symptoms? Symptoms of an immediate reaction, whether the symptoms are of a late reaction, or the symptoms are of a severe cutaneous adverse reaction, which are mainly T-cell mediated, right? So you inquire about the symptoms, right? And then the timing of the reaction, the temporal relationship of the reaction and the drug, right? Within minutes, within hours or days, right? And then was it with the first dose or after multiple doses? And how was the reaction treated earlier? Was the patient given epinephrine or adrenaline, right? And has the patient tolerated similar antibiotics since the reaction? So those are the things that you want to ask in the history to say that, okay, this is to confirm that this is a true allergic reaction, right? And according to the reaction, you can stratify the patient depending on the risk, right? You can stratify into low risk, moderate risk, or high risk. So the low risk patients, you think, this reaction can't be an allergic reaction, right? So in that case, you can prescribe the antibiotic that you want, right? So if they come with an penicillin allergy history, just with pruritus, without a rash, or a very remote history, like that's something that happened long time ago, then you can do a direct challenge or a graded challenge. Usually we do the direct challenge with amoxicillin or graded challenge with amoxicillin. You can use the pediatric suspension, right? 500 milligrams. So you can divide into multiple doses and give slowly, or you can, even in low risk patients, you can do a direct challenge. So if the patients could tolerate amoxicillin, right, you can prescribe the drug that you want. And if the patients are in the moderate risk group, it's just mild urticaria, mild reaction with features of IgE-mediated reactions, but not anaphylaxis. Ideally, these patients need to be referred for a skin prick test to confirm. But if the skin prick test is not available, you can do a graded challenge with amoxicillin. Right? So again, sometimes it's skin prick test is unavailable. So you can do a graded challenge in your setting under observation. Right? If the patient is at high risk, right, that patient has developed anaphylaxis or recurrent penicillin reactions or severe urticaria and angioedema, and these patients need to be evaluated properly by an immunologist. And when they have done the amoxicillin challenges, only very rarely these patients have developed a reaction. So you have to do it ideally under observation, and you can do it in your setting. So skin prick test with penicillin, right now, as Danishka mentioned, right, these drugs are very small molecules, so they bind with the serum proteins and form various metabolites, so antigenic determinants. So there are two antigenic determinants for penicillin. One is called the major determinant, which is the benzyl penicillyl oil. And there is a group of other antigenic determinants which are grouped as minor determinants. And these major determinants, if you test with the major determinant, you can identify about 80 to 90% of the patients, right, with the skin prick test. But if you add the minor determinants into the testing, then the accuracy of the skin prick test will increase to 98%. Now, what happens is now when the major determinant and the minor determinant mixture is not available commercially in Sri Lanka, and some countries also it's not available. So in that case, what we do is we use oral penicillin as the major determinant and the IV penicillin as the minor determinant, and do the skin prick test along with the amoxicillin and the culprit penicillin or the cephalosporin. And if all these the skin prick test for all these drugs are negative, then you can perform the intradermal test. And for 100% accuracy to confirm that the patient is not allergic to penicillin, you can do an oral challenge if both the skin prick test and the intradermal tests are negative. Now, this is how you do the skin prick test. You put the correct concentrations of the drugs onto the forearm, and then you prick with a lancet. Observe the with the positive and the negative controls. You do it with the positive and the negative controls, and you read the reaction after 15 minutes. If the skin prick test is negative, you can proceed with the intradermal test, and intradermal test is negative, you can do the provocation test or the graded challenge. So the skin prick test and the intradermal test should be done only in patients with a history of beta-lactam allergy. Not in all patients who need beta-lactams, but only in patients who had a reaction previously to a beta-lactam antibiotic. Right? So mind you that you don't do skin prick test for all patients who need an antibiotic, and should be done by an experienced person in an appropriate setting with correct non-irritant concentrations of the drugs. You have to prepare the drug concentrations appropriately for that drug, and then interpreted carefully with positive and negative controls. Now, what happens in our setting? Now, I don't know whether this is still done in Sri Lanka, right? Penicillin skin testing, is it done in your institution? Still? Used to be done in many institutions that I worked, and I know that it's been done. This skin testing is done for non-beta-lactam antibiotics as well. One institution where I was there, they did skin testing for gentamicin, Vancomycin, all the drugs that they wanted to give to a patient, especially after a case of anaphylaxis. Right? So the skin testing which is done in Sri Lanka is very irrational and very unscientific, right? Because it's done for all patients who need penicillin, right? So when we were like house officers, we used to do this penicillin skin testing for all patients who need penicillin before giving penicillin, right? And the way they are doing it also not like standard, because standardized, like different institutions use different concentrations in maybe in the same institution, different wards use same different like dilutions of the drugs. So it's very logical. It's the Sri Lanka was the only country which did this test. I don't know whether it's still done. I don't know in Kandy whether you are doing still penicillin skin testing, but you should stop that, right? Because it's very unnecessary and it's very illogical. Okay. And the graded challenge, and it can be done in if the skin prick test and the intradermal tests are negative, and even directly in patients with a low risk history. And protocols in children have recently included amoxicillin as the first line without proceeding with the skin prick test, except in cases of anaphylaxis, because it's very difficult to do skin prick tests in children. It's time consuming and painful. So graded challenge can be done with gradual increasing doses, with 2 or more doses right? Starting with a very low dose, like 1/10 of the normal dose, and it has to be done under supervision, right? So you can gradually increase the dose. Usually, it's easy to do it with the pediatric suspensions. So you can divide the dose accurately with pediatric suspension. If you want to take 500 milligrams of amoxicillin, you take about 20 ml of the suspension, and then you divide, right? You give about 2 ml first, and then wait. With each interval, you have to wait 30 minutes with each dose. What happened with the case one, who had multiple antibiotic allergies, right, who was awaiting GA, and this was the clinical evaluation. The amoxicillin reaction happened a long time ago, about 8 years ago, just itching, angioedema, chest tightness. Cloxacillin about 7 years ago, again about a rash. Cefuroxime, long time ago, rash, abdominal bloating. Clarithromycin recently, again bloating, rash, right? So to confirm whether it was a type 1 reaction, especially with the betalactams, I did a skin prick test with positive and negative controls, and they were all negative. These are the drugs that I used, and the intradermal test was also negative, and I did the oral amoxicillin challenge, and then she could tolerate 500 milligrams of amoxicillin. Right, so what happened with the case 2, who developed anaphylaxis during GA. So I did the skin prick test with all the GA drugs as well, the drugs that were given for GA, and also with the benzypenicillin, oropenicillin, amoxicillin, and ceftriaxone. And she developed a reaction to ceftriaxone as positive skin prick result within minutes of the ceftriaxone, and also she developed signs and symptoms of anaphylaxis during testing. So that's why it's important that these tests are done in an appropriate setting where resuscitation facilities are available. Now, as Danushka mentioned, the tests for non-betalactams and late reactions are not validated, and they have low sensitivity specificity, and skin prick test cannot be done for non-betalactams because they are not validated. And you may be able to do a graded challenge, right, because most of the patients can tolerate the culprit non-betalactam antibiotic, but you have to avoid testing in patients who had a severe late reaction, severe cutaneous adverse reactions, such as GRES, TEN, or SJS. Now, to summarize, right, so if now you have a patient with a history of penicillin allergy, let's say the patient says that she's allergic to amoxicillin. So in the history, you have to evaluate whether it's truly an allergic reaction and whether it's an immediate reaction or a late reaction. So if it's an immediate reaction, so according to the rescue stratify, right, if it is a high-risk patient that who had developed anaphylaxis previously, so it's safer to use a non-betalactam antibiotic in that patient, right? So it's safe because the patient had developed anaphylactic reaction previously, but you can also, you can try a non-cross-reactive cephalosporin or a carbapenem, but in a monitored setting, right? You can, in a monitored setting, you can give a non-cross-reactive cephalosporin or a carbapenem, but you have to avoid all penicillins and avoid all beta-lactams which share the same side chain. If it is a moderate risk patient, right, just mild urticaria, safe to use non-beta-lactam, or you can use aztreonam or a carbapenem. But you can also try a non-cross-reactive cephalosporin under observation. And ideally, these patients need a skin prick test to confirm the hypersensitivity reaction. And if the skin prick test is negative, and you can do a challenge then, and then they can tolerate any beta-lactam. And if it is just a low-risk patient, just pruritus or a remote reaction, you can use a non-cross-reactive cephalosporin safely, or even you can do a direct challenge. And if it is a delayed T-cell mediated reaction, if it is a severe cutaneous reaction or the serum sickness or organ involvement, then you can't use any betalactam. You have to use a non-betalactam antibiotic, or you can even use aztreonam. You have to avoid all penicillins, cephalosporins, and carbapenems, and you can't do any drug challenges or drug testing. And if it is a non-severe reaction, just itching, maculopapular rash, which is more common, it's safer to use cephalosporins, aztreonam, or carbapenem. And penicillins may be used if you can monitor the patient. So if you think it's not an allergic reaction, you can use the antibiotic that you want. Okay, so in summary, like antibiotic allergies are overreported, misinterpreted, and unverified, and which can cause serious problems with regards to patient outcomes, antibiotic utilization, and development of resistance. And it is important to determine the best management option by evaluating the patient clinically, right, depending on the severity and the type of reaction, and also you have to consider the cross-reactivity. And it's important that you confirm if the patient had a type, you think that patient had a type 1 reaction, it's important to refer for a skin prick test. Thank you. I think we can take up questions at the end.